I'd like to thank the organizers, of course, for inviting me. It's very kind. It's been a fantastic, conference. I haven't been to a conference that has so many just fantastic presentations. I'm a little intimidated, but we'll see where we get to. So I'm going to, as I mentioned, or as was just mentioned, discuss our experiences with bringing together and combining the workflows in radiology and pathology. So this is a system that's actually live. It's been live for several years, and it's evolved over time. And when we talk about what we do, combining pathology and radiology reports into one platform, it's very often we're very often met with skepticism. Not cynicism, but skepticism, saying why? What's the value of that? Why do you want to do that? And so I'll attempt to walk through our experiences and show you what we've developed and show you how this is valuable in many ways. This changed my practice as a pathologist. And what I produce as a pathologist is much more, I would say, much more clinically useful, having developed this very close working relationship with our radiology colleagues than what we were doing before. And hopefully I'll make that case. I have no disclosures. I'm a pathologist, I should point out. The one disclosure I say, my chairman would call me an informaticist, but I say, no, I'm a pathologist. And what got me into this business in the first place is about 10 years ago or so, I sent an email. I think my chair was asking for soliciting subjects to talk about the next faculty meeting. And I said, well, why don't we look at the website? It's terrible. And his response was, well, do you want to fix it? It would be great for your career. And I said, no, I don't want to do it. He said, you better fix it. You're going to be, no, he didn't say that. But anyway, that's literally how it started. I said, the website, let's talk about the website, it sucks. And then he said, okay, well, why don't you go ahead and fix it? I'm like, okay. So I said yes, and that's been one of my problems in saying yes to too many, well, you know, there's some benefit, but, and so he took that and said, oh, wow, Dean's an IT guy. And so every time, so naturally that evolved in becoming the informatics guy, and here I am, 10 years later. Okay, so we'll review our experiences at UCLA. So as I mentioned, this is a live system that we developed in-house in integrating pathology and radiology. So about, as I said, 10 years or so ago, the chairs of radiology and pathology got together, or vice chair got together and talked about what is the value of putting this together? Why don't we combine workflows? And our chair said, oh, great, I know this guy, he's really good with websites. Bring him in from pathology and he could work on that with you. That was me. And so we first assessed the value of it, and then we assessed the environment out there, and are there any vendor solutions, or is this something that we would build in-house? And UCLA has a lot of resources, and so in the end it was most beneficial for us to actually build it ourselves, and that was actually a very, very, very valuable team building exercise. And then I'll discuss the continuing challenges that we have and the benefits that this is shown. Okay, so why diagnostic integration? It's a good question. First question, why do we do it? Well, a lot of this focuses on cancer diagnoses. Cancer, when I first got into lung pathology, and the reason I got into lung pathology, I was actually a renal pathologist, and I was looking for a job at UCLA, and they said, well, yeah, but we really need a lung pathologist. Can you do that? Yeah, okay, I guess so. So if you keep saying yes to all these, when people ask you questions, you get a lot of opportunities that can really change your career in funny ways. But when I first got into lung pathology, as many of you may remember, all we said when we got a biopsy report was non-small cell carcinoma or small cell carcinoma. That was it. That was it. Think about that. That wasn't that long ago, 15 years ago or so. Nowadays, we have to say adenocarcinoma, the subtype of adenocarcinoma, the molecular changes, any cytogenetic studies we do, PD-L1 expression. So it's gotten really, really complex, truly. And then the radiographic studies are also complex. It's not just CTs, there's PET studies, and there's differences between the diagnostic and the interventional studies. So it's gotten a lot more complicated. So maybe if there's some way we can sort of combine that into one platform, there'd be a lot of value in that. But I think if we just think of it as a cancer tool, it's a little bit narrow. A lot of our work is, and a lot of our best work, I would say, is probably done on our benign diagnoses. So when I get a biopsy, as many of you remember, we have a benign diagnosis. It's often kind of mysterious. Yeah, this is just a scar. So there's this nodule there in the right upper lobe. So yeah, it's a scar, or there's some necrosis. And the clinicians don't necessarily know what to do with that. But by working with the radiologist, you can actually put together a pretty logical sort of explanation as to what it is or what to do next. So we do this, this integration to improve the diagnostic alignment, basically. And so our system, which we call the Integrated Diagnostic Report, or IDR, that combines this together. And it generates a single aligned report for their clinicians. And I'll give an example of a couple of them. Okay, of interest, the Institute of Medicine in Washington just recently, or in 2015, published a white paper talking about the importance of diagnosis in healthcare. And this is a follow-up from a seminal work in 1999 that looked at the cost of medical errors in general. And that was a multi-billion-dollar problem in the United States and obviously worldwide. And that there needs to be a lot more emphasis on preventing errors. This next publication that came out, as I said, more recently in 2015, just focused on the diagnostic process. And then I took a couple of lines out of the executive summary. They mentioned improving the diagnostic process is not only a possible, but also represents a novel, not only is possible, but represents a, moral, I can't read very well with my glasses, moral, professional, and public health imperative. And then diagnostic errors stem from many causes, including inadequate collaboration between and communication among clinicians, limited feedback to clinicians, and about their diagnostic performance. And they came back with 8 recommendations on how to address these problems, which I'll come back to a little bit later on in this talk, after reviewing our system. So, okay, so with that background, we first put together this system. I say prototype, it was actually the first version, I guess, of the Integrated Diagnostic Report. And it went live, and what it was basically was a very, very fancy pathology report, where we basically took radiology information and we pasted it into the pathology report. It was sort of a circular stepwise workflow. So the case was never finalized until after the radiologist was finished with it. So there would be a little bit of delay, I guess. And this is an example of the front page of the report. And you can see the pathology diagnosis. Is this working? You can see the pathology diagnosis in the middle of the report, and then some representative images of radiology and pathology studies. The next page, you can see the rest of the pathology report, and then at the bottom of the page, you can see the beginning of the radiology information, where they talk about where it is and how big it is, and then they give a clinical stage. So in this case, T3, N2, M1A. So that's actually quite useful to put on a pathology report. That was the pathology report, it had everything there. And then, of course, we would also add the additional molecular studies as they came out. So it was actually quite a good product, I think, where it comes to like pathology reports. You put a lot of useful information in there. But the workflow in generating it wasn't particularly, it was a little arduous. The pathologist does their work, then they'd send the report to the radiologist, they'd add their stuff, then the radiologist would sign out, and so it would take a little bit longer to get the final sign out, the turnaround time. But the actual report itself was very nice. I like to think of it as this. Does anyone know what this is? Apparently, well, actually, I'm not sure what this is. But I went to Google and I typed in first MP3 player, and this is what came back. So maybe that's the first MP3 player. But it's basically, it doesn't look like much, right? The first MP3 player. But actually, you know, this is really a seminal product. It really changed, made a big difference, even though the first system didn't look very well. What I think this product, what this first report did was it was a great team building exercise. And it forced the radiologists and pathologists to start working together, which we never really did that much before then. Before then, we were collegial, friendly. We met at tumor board. But when we were starting to put the reports together, we would call and talk to each other about what the report or what our findings were. And that actually made a big, big, big difference. So prior to implementing this system, like most pathologists, I guess, if I had a tough case, I would just take it down the hallway and show my colleague. And they tend to say the same sort of thing that I thought. Once we started working with the radiologist, the first thing I did was call the radiologist if I had a tough case and get their impression. And that was often very, very different. So the radiologist would sometimes say, I'd have a case and it would be negative, or I couldn't make much of it, and I'd call the radiologist. And he may say, yeah, I don't think this needed to be biopsied. The pulmonologist just wanted to biopsy it, or the patient was very nervous, so he went in there, so I'm not surprised he didn't find anything. Now, obviously, they wouldn't put that on their requisition, right? So you're not going to be able to dig that out of the chart. But by picking up the phone and talking to the radiologist, it really, really helped the pathologist feel much more comfortable with what they found. And you don't get that, obviously, from talking to your colleague down the hallway either. So it was a really, really, really useful sort of relationship to build between the pathologist and the radiologist. Or on the other end, there would be sometimes with the pathologist you weren't sure what it was, and then the radiologist would come back and say, well, don't worry about it. Just say you're not sure or be inconclusive, because the next thing we'll do is we'll have the patient back in 3 months. We'll repeat the imaging. And if it's grown at all, then we'll rebiopsy it. And if not, we'll just continue to follow. Or they'll say something like, well, we'll just ablate it. So just say whatever you want. We'll bring the patient back and we'll ablate it. So by talking to the radiologist, you get a perspective on how the case is being interpreted and how the information is being handled, which you don't get otherwise from pathology. So while this system, as I mentioned, this report was kind of a laborious process, it really was a great team-building exercise. And it really, really affected how we work and what sort of information we were able to produce. Okay, so this is the newer report. So the original idea, which is what we were able to implement on the next version, was to make it more of make it a dynamic web-based report. Okay, so and I'll show you some screenshots in a second. But so this is the new report, and it's much more convenient for the pathologist and the radiologist to use. We launched it in about November 2014. What this system does is it auto-generates by grabbing information from the pre-existing pathology and radiology reports. So unlike the previous system, which forced the radiologists and pathologists to sort of work differently, this system doesn't. It allows the pathologists to live in their world, the radiologists to live in their world without changing or affecting their workflows, but it brings them together. Okay, so it's sort of improved parallel. This will be the only sort of technical diagram I'll show you, but again, I don't have a pointer very well, but if you see on the left side of the picture, if you can read, the radiologists and the patients and the pathologists all do their own thing. The radiologists do their work, the patients get biopsied, the pathologists do their work. Then the pathologists sort of instigate the IDR report, which then goes into the various information systems in the hospital, the laboratory information, the radiology information systems, and pulls the information, and then it gets sent to the radiologist. The radiologist looks at it, which is part B, then they provide a correlation comment, and then they shoot off the report to the rest of the hospital. Okay, so don't worry if you can't read the information, but you get the idea of what the report looks like. So this is a snapshot or a screenshot of when you go into the system, you log in. I was thinking about actually having a live test system and showing a test system, but I was afraid it would crash, and I thought Ireland was not the place to challenge Murphy's Law. So I just took some snapshots. I was really impressed actually with the QPath presentation and Laszlo's presentation from yesterday. But I'm not that brave. So anyway, so this is a snapshot of the system when you log into it. You just use your regular AD, regular healthcare access account. Then when you log in, this gives a list of cases. These are all de-identified that you've worked on in the past or that are in some sort of state of progression or so. Then to create a new case, you click on the new case button, you enter the MRN, and depending on what type of case you want to create, a lung cancer case or prostate or just a conference case, you enter the patient's MRN number, and then it very quickly finds all the information, all the previous cases that have been signed out. You select the case that you want to use. So in this case, we would choose, say, the SSU 17, the fourth case down, and just click on View Report. Then it grabs the information, again, pretty quickly from the pathology report, and then puts it all into the Integrated Diagnostic Report, the IDR. It grabs images. So the one thing that pathologists have to do additional, which they didn't do before, it's not a big ask, I think, but the one thing they have to do, and we now know how to ask them if they don't want to. We threaten them. But we asked the pathologist to put images, 1 or 2 representative images of the biopsy into the case in the LIS system. But it grabs all that, and then the pathologist looks at it and then clicks on the next button, which is in green, and then it sends the information to the radiologist. And the radiologists add their part, and then this is what the final report is. So this is the actual report. It's as I said, it's a clickable web-based portal. And each of those, you can't maybe see the outline very well, but each of those words like assessment, pathology, radiology, ancillary studies, those are actually clickable tabs. And so when you click on them, they'll open up and show you what you need to know. But all the pertinent information is just at the top in this report. And there's some radiology information that's below the fold, which you have to scroll down a little bit. But you can see the diagnosis, you can see a representative image, and see the radiology study where it was biopsied. Okay. So, again, to show some of the features of the report, it's patient information is anchored to the top. You have the different navigation tools or navigation tabs to tell you where you want to go. And like Eric was saying, you don't want to clutter your report with a lot of unnecessary information right at the front. So the advantage of having a sort of electronic report is you can collapse things like the gross description inside a tab. So you never have to bother looking at it if you don't want to. But if you want to see how big the biopsy pieces were, you can click on the gross description and it'll open up. But you can see you can instantly go to the pathology, radiology, or molecular studies tab. So one of the frustrations with our oncologists is they want to be able to find the molecular studies real fast. This is the pathology tab. They go to the molecular, this is the radiology tab. Going to the different tabs sort of show you basically the sentient, or the salient, features of each biopsy or each report. But also the molecular studies, so they can see what has been ordered, when it was ordered, and what status it's in. And if it's positive, if the results are back, you can get the results right here as well. So it's a one-stop shop for everything associated with that biopsy. And that's the idea. And of course, it's web-based, so you can put anything you want on there. So we add things like references, so tabs to references. So it's great to put references in your PDF reports, but it's really nice if you can just click on it and it instantly opens up. So that's possible with this more sort of dynamic report. And then you can also have access to the images. So this is very useful for me as a pathologist presenting these cases at Tumor Board, because the images are right here. I used to spend a couple hours, 2.5 hours, preparing for Tumor Board every week. Now I just pull the cases up and review them. I take 10, 15 minutes to prepare for Tumor Board. So that's one of the carrots for the pathologist. So we have 2 live versions right now, the lung report. Lung, probably as much because I was a lung pathologist, but also the lung is pretty good. We went with lung because it has a lot of these different diagnostic studies which are really useful to attach to the report. And then we also have a prostate version. We have a big fan in urology who uses this report actually when counseling his patients. So he'll have the patient sitting in his office and he pulls the report up. And you can see the images and you can show where the needles are and show what the diagnosis is associated with the biopsy for that needle. And then he has, by pulling up the radiology images, which are more useful for the patients than the pathology images actually, he can give a very sort of, full counseling opportunity to the patients. So in the charts, these exist in the charts. They're kind of hard to find, which are actually one of the problems that we're working on right now. But it's a hyperlink to the report in the chart. And so because they require an extra click, I think that probably reduces the amount that people use it. And if it was a little easier to find it, I think more people would use it. The other way that we send it around is it can also be emailed. So you can email the system. So that when the radiologists finish the report, they always send an email to whoever originally ordered it. So everyone who orders a biopsy, they'll get that report. They click on that hyperlink, and it takes them straight to the report. And then we also have a patient-friendly version, which we talked about yesterday as well, that has information about radiology and pathology that we're able to print out and give directly to the patient. So what are the benefits? In pathology, radiology, it's an image viewer. It's a very useful presentation tool. That's one of the things I take to my pathologists who often ask, why are we doing this? It also importantly increases exposure to the lab and the hospital. So a lot of people are seeing pathology and what pathologists can do, which they don't otherwise see because it sort of lives in a black box or lives off in underground. But it's sort of increased our exposure in the hospital, which is very helpful. And it can be an educational tool for our trainees. It could, in theory, increase efficiency and value to the health system. It can facilitate, and I'll talk about this in a second, quicker and contextualized communication between clinicians. So as a clinician, you can look at this report and say, if you're a surgeon, you can email the report to a radiation oncologist and say, is this patient candidate for radiation oncology? And that's a very, very contextualized message. The radiation oncologist doesn't have to go into the chart to find out all the information. They have all the information right there in the email or in the report. How much they use that, we have to discover. And it can be a marketing tool for patients. So we like to show patients this is what we do. And then patients, again, in theory, potentially shorten time from diagnosis to definitive treatment, because it can kind of work like a virtual tumor board, right? So you can have this very contextualized discussion between oncologists and surgeons or radiation oncologists or diagnosticians. So it can work as a virtual tumor board and in theory, quicken the time to whatever treatment is useful. And as Dr. Marks in urology uses it, it's a very educational tool, very useful educational tool for patients. So coming back to those 8 goals in that the IOM paper talked about. 1, facilitate more effective teamwork in the diagnostic process was the first goal. Yes, it does that for sure. 2, enhancing training in the diagnostic process. It does that for sure. 3, encourage health IT to provide more support in the diagnostic process. Absolutely, it's an absolute, the IDR requires on that. Develop and deploy approaches to identify, learn from, and reduce diagnostic errors and near misses in clinical practice. It does that. I'll show you an example. Develop a culture that supports improvements in diagnostic performance. It certainly does that. So that's 5 of 5 so far. And the last 3, it doesn't really address, but wasn't exactly panacea. Okay. All right. We published our initial experiences a couple years ago in terms of how long it takes people to do it, what people's experiences with using the report. I won't go through all of that. One thing I'll just show you is the amount of time it takes a pathologist and radiologist to do the reports. And I think now it's actually much shorter than this, but I don't have more recent data. But it takes a pathologist a median about 35 seconds to create this report and send it on to the radiologist. The radiologist about 120 seconds actually, because they have to type in or add a correlation comment sometimes. But I actually think it's a little shorter than that now. But is that a problem for the radiologist? Well, we'll see in a second. Okay, usage statistics. So we've created a little over 2,500 cases as of a couple weeks ago. Most of them are prostate cases, 1,500 are prostate, about 900 are lung cases. And we also have this conference-only function where I can create a case which I use it as a presentation tool, and that can be any type of pathology report in the world or that we have. We have different, when the radiologist gets the report and they add a correlation comment, they have 4 different choices. They can say there's a correlation, the radiology and pathology correlates, and that occurs about 83% of the time. They can say it doesn't quite correlate, but defer to pathology. That could be like the radiologist is very suspicious about a cancer, but the pathologist finds a granuloma. It's a granuloma. Sometimes it'll be a sampling error or incomplete representation. And the last one is there's not a correlation available. Those are conference cases. These are the amount of reports that are created per week, I think, from November 2014 to September 2018. And as you see, the number have increased over that time. Now, we haven't increased the number of biopsies that we're doing, but there's more sort of buy-in from the pathologist and radiologist in terms of actually doing the cases. But very importantly and interestingly, if you look at the graph underneath there, that is the turnaround time it takes from when the pathology report is signed out to when the IDR is completed. And something happened in December 2016 or January 2017, and I can only speculate. I think the radiology chair encouraged the radiologist to be faster by providing incentive, financial incentive to do these reports, or he may have threatened them with loss or some sort of fear. I don't know, but if you look at the turnaround times after January 2017, it's extremely short. It's extremely short. And so what I take from that, not just that there's a great incentive, but that means the system's got to be pretty easy, and they've got to enjoy using it, and, which is my impression when I talk to them. They really, the radiologists I work with really like to use the system. So if it wasn't easy, you wouldn't have that level of compliance. It wouldn't be that flat. So that turnaround time is very, very impressive. Before then, I think that the radiologists in particular they had a difference, there was a difference in messaging and how important these reports were. But then the radiologist chair stepped in, and I think because the system was so useful, they were able to get it. These are the number of views. We've had 6,500 views directly from the charts, another 591 views through email, and 153 different users through email. I'm not sure how many come through the chart because we can't tell how many people are looking through the chart. But with 153 different users, that tells us we don't have 153 different submitters for lung and prostate cases. That tells us that the clinicians are emailing the cases to other people. So that email function is being used, and probably the majority of those are recipients that are getting reports from clinicians. And then this shows, the graph on top again shows the amount of cases that have been created per month, and then the graph on the bottom shows the case views. And recently, in the last year and a half, you can see the number of views, almost 500 per month, has really jumped up. And that wasn't following like a marketing strategy. This is just sort of an organic, sort of eventual, people are becoming more and more aware of it, and they're actually going to the trouble and clicking on the reports to see what they show. Okay. All right, so just a couple cases, just from the last 3 or 4 weeks, actually, to help highlight, I think, the value. So this is a biopsy. This is a typical biopsy I get. On the left, 89-year-old man with history of prostate cancer, status post-treatment, now with a right upper lobe lung nodule, 2 centimeters. And you can see on the left, that's not normal lung. That's definitely lesional tissue, right? It's not like a missed biopsy. Then a high power on the right, what do we see? Nothing. It's just a fibroelastic scar. No one's going to make anything of that. No one's going to, you might throw a Congo red stainer at it, but there's no cancer in the biopsy. And it's a lot of tissue, and it's definitely lesional. So I think most pathologists would just sign it out as fibroelastic scar. So, I'm in the habit of calling the radiologist, asking their thoughts. And the radiologist said, no, I'm really worried about this still. Okay. So I put in this comment saying something about no definite malignancy, but the radiologic lesion of concern may not have been adequately sampled to render a definitive diagnosis. The radiologist said, well, you could have been more definitive and more pushy about it. And so when the radiologist went in there, and he added his assessment summary. And he said the concern for lung cancer remains high, which is not at all the impression you got from looking at that biopsy. And that wasn't like a suboptimal biopsy. That was a big biopsy. So the radiologist said that. No, a pathologist would never have said that based on the biopsy. So they read that. And again, this was just a couple weeks ago. They repeated the biopsy, and this is the TTF1 staining. So this is an adenocarcinoma. And radiographically, there was a different, it looked like there were different areas to the lesion. And so he biopsied the other lesion. And based on this, this may be the reason we went back and caught the cancer. Here's another case. My colleague signed out. Again, it's not a small biopsy, lots of lesional tissue. He signed it out. There's some calcifications, there's some fibrosis, but no obvious tumor. Calcified and fibrotic fragment tissue, negative for neoplasm, negative inflammation. The radiologist came in and said, though, he added a longer comment. He said the differential considerations. Well, he said the pathologic specimen does not provide a conclusive evaluation of the nodule, first of all. A pathologist wouldn't say that. The radiologist would say that. Differential considerations include granuloma to scar fibrosis versus primary lung adenocarcinoma. So this is after getting the biopsy report back. So incidentally, interestingly, my colleague and I who developed these reports, we were talking to an oncologist who's I guess you put him in the skeptic category. Not cynic, but a skeptic who didn't use these reports very much. And we asked him, well, why don't we just pick his brain, why he doesn't use the reports very much. He said, well, I get all the information from the HR. I'm pretty happy with my workflow. And then we said, well, what do you think about this? What do you think about this diagnostic assessment? And he was kind of shocked, like, oh, well, that changes things a lot. I didn't know that was there. It made us think about a couple things. Like, if people aren't seeing this, is this a bad thing, maybe? But then he sort of calmed down a bit and said, well, but you know what? I would have been fine. That diagnosis is a bit confusing, and I would have called the pathologist, and it would have been fine. Did you hear what he said, though? Did you hear what he said? He said he would have called the pathologist. He didn't say he would call the radiologist. And the radiologist was the one who said, no. Remote imaging, go ahead and recommend further evaluation of imaging of the nodule, and maybe look at some other CT imaging. He's a smart guy. He would have worked out in the end. But his impression was to go back to the pathologist. And maybe for many of these cases, the radiologists are the ones who are saying, this is what you want to do from here. Okay, and then this is a case, one of my cases. again, lesional tissue, 67-year-old woman, history of leiomyosarcoma. And they went in and they biopsied some areas. And to me, it looked like there was some pneumocyte hyperplasia. The atypica is pretty mild, but there was an increase in NC ratios. It looked to me like an AAH. I don't know why there's so much fibrosis here, but in some areas you can really talk yourself into calling this atypical adenomatous hyperplasia. And I called the radiologist, let him know, and he's like, well, doesn't look like adenocarcinoma in situ. It seems pretty fibrotic. I said, yeah, I see fibrosis here. He said, okay, that's fine. So signed it out as lipidic pattern neoplasia, negative for leiomyosarcoma, which it is. Luckily, the surgeon didn't believe us. The radiologist believed me. He said, oh, well, okay. It didn't look like it, but okay. This is the lesion. Oh, here we go. This is the lesion here, actually. I'm not a radiologist, but that does not look like an AAH, right? Do you see it? And so the surgeon was still concerned that might be something more worrisome. So she went in and she took it out. And sure enough, that is not what we had seen. And what we had seen, there's a lot of background interstitial fibrosis. And they had accidentally sampled, this is a patient with a big smoking history. So she had smoking-related interstitial fibrosis. I think there was incidental AAH. And I think had I actually looked at the images and we had compared the images and discussed the images, we might have been able to catch that. It didn't matter. In the end, she went and took it out, and so it didn't make so much difference. So there was a misalignment. So the radiologists, pathologists also need to be looking at the images themselves. Okay, so to summarize, sorry if I went a little over, it is possible to create these combined workflows. There is a lot of value to them. Try to avoid over-automation, though. The computer scientists I work with, they like to automate everything. But if you automate everything, you'll take away the communication, the interaction between the pathologist and radiologist. So be a little careful about that. And then if a hospital is interested in developing one of these combined reports, you can look around, see what's out there. There aren't many vendor solutions that actually do this at this time. And if you have the resources, it's maybe worth considering creating yourself until a vendor solution comes along. And that's a great team building exercise. You get to know your colleagues in other departments much better by doing so. And then we're right now in the process of working out how the clinicians, we know they access the system, we know they look at the reports, we don't know how it changes their practice or how they use the different features. So we're in the process of getting that data and putting it together and see how it's actually changing the field. These are my colleagues I work with. These are the radiologists I work with. And this is Corey Arnold, the computer scientist, helped build this with me. And, but it's been a great pleasure to work with these people and change the way we practice. And that's all I have. Thank you.